So our next speaker is Dr. Arnold Silva. He's a familiar name in nephrology to those who've been in the Treasure Valley. He's the director of the home hemodialysis and peritoneal dialysis programs at Boise Kidney Hypertension Institute. As such, he has been very active as an independent investigator in the basic sciences and clinical research throughout his career, and currently acts as a principal investigator on projects for the Boise Kidney. He received his PhD from the University of Arizona in Tucson, studying the physiology of membrane transport and cell volume regulation before receiving his medical degree from the University of Arizona. He followed that with residency training in internal medicine and nephrology fellowship through UA's affiliated hospitals. I know Dr. Silva because he's married to our former winter clinic committee chair, Dr. Denise Mill, and he decided to wait until she wasn't the chair to have him come talk to avoid any appearance of a conflict of interest. With that,
Great.
I will let you.
Thank you. Thank you. Pleasure to be here. And I think you can hear me out there. Okay. And well, I'll tell you at the start here, my talk will hopefully be a little shorter, but it'll also not include any videos, so it will alleviate technical challenges. So I also love this format where we actually have a real projector. And this allows me to use a laser pointer, which if you've been to presentations maybe in the last few years where they're using big television screens, laser pointers disappear in those. And so I'm often up there dancing around trying to point to things. And as Denise will tell you, I'm no dancer. So that usually doesn't work very well. But oh, okay. So I might still have to dance, Steve. Okay. Well, welcome everybody, and maybe I should say welcome intrepid travelers. And Steve, I did see your Highway 21 sign on the way up, so I didn't have to go that way, fortunately. But anyway, what I want to do this morning is to give you an overview of where are we with chronic kidney disease, and then also talk about some recent advances as far as the research world goes, and things that have been completed, and then some exciting things that are in progress. So a bit of housekeeping. These are my disclosures. And as an overview, I'm going to begin with talking a bit about economics and the burden of disease with chronic kidney disease. Move on to talk about the comorbidities and our newer therapeutic approaches, and some of that's going to be from studies that have just been completed in the last few years. Talk about our current therapies, where are we as far as disease progression, and then finally I want to talk about cell therapy for chronic kidney disease. And if you haven't heard about this, this is an area that really didn't exist until about 5-6 years ago. So brand new stuff to share with you today. Well, overall, chronic kidney disease, it's expensive, places a significant burden on the healthcare system. And when we talk about renal replacement therapy, dialysis and kidney transplant, these consume really disproportionate amounts of the healthcare budget. And this is a staggering number, this middle bar here. About 7% of the annual Medicare budget is consumed by about 1% of the population. So if you think about that, that's a lot of money that gets devoted to chronic kidney disease, and in particular into end-stage kidney disease with our patients on dialysis. We also know that the later patients get referred for CKD, the worse their outcomes are. And finally, the recent approval of newer therapies, and I'll say a little bit about SGLT2 drugs because they're so much in the news these days. We're able to slow GFR loss, but we still don't have a cure, but we're working in that direction to hopefully keep people off of dialysis or the need for a kidney transplant. Well, this is the CKD population, and this goes by decades here with projections to 2030 and to 2040. And it's projected to see a 50% increase in this population over the next couple of decades. So that's a staggering amount. And Dr. Noonan talked about how many people with AFib, which is also a large number, but if you look at our projections by 2040, roughly 90 million people between the US and the European Union. So that's a lot of folks with chronic kidney disease, and that's across all 5 stages. Well, if we talk about cost, a lot of money gets spent. We're spending about 80 billion on chronic kidney disease and 50 billion on end-stage disease. So that's patients on dialysis. And when you look at the dialysis patients, it costs about $100,000 per year per patient just for dialysis cost. And that doesn't include all the other things that patients get hospitalized for or other specialties that are involved in their care. Now, on the left, I don't know how well you can see this, but these are various numbers, and the different colors here are stages of chronic kidney disease, stages 1 through 5. And what you might notice right at the top here, the red markers for stage 5. So these are patients basically at end-stage disease needing, or about to need anyway, renal replacement therapy. And you notice those numbers really don't change much even with our projections. And part of that is that these are patients who die before they get to dialysis. And so the patients that we really need to be focused on is here, those with stage 3 and probably early stage 4 chronic kidney disease, because that's where we still have an opportunity to intervene. By the time they get to dialysis, we haven't really ignored these patients in the last few years, but we really have turned our attention away from dialysis studies and really focused, I think, really where we should be is on chronic kidney disease, not on dialysis. Well, here's just another way of looking at how prevalent chronic kidney disease is, and this is regardless of their type 2 diabetes status. So in the US, probably 35 million or so with chronic kidney disease, about 1 in 7. And over half of these cases are non-diabetic patients. But here's another number that keeps coming up in more recent clinical trials, that about 90% of patients with chronic kidney disease are unaware they have the disease. The Fidelio trial that was published in New England Journal in 2022, December of 2022, and that was the study that looked at finerenone therapy, which is a mineralocorticoid receptor antagonist. I probably can only say that once, so I'll refer to that class of drugs as MRAs. And so they looked at mostly kidney outcomes. So the primary endpoints in that study were kidney outcomes. And large study for us in nephrology, over 6,600 patients. And that 90% number, that became something that was really moved into the forefront, because most of these patients who were in this study didn't even know they had the disease until they were identified by their primary care physician and then actually referred as a possible study participant. So those of you out there in primary care are really the first heroes, and probably go under-recognized, but it's really you that's picking up these patients with chronic kidney disease and then bringing them to the attention of nephrologists and research nephrologists like myself to hopefully get them into a clinical trial. So just a number to think about. And we know that we used to think about all these independent silos, so to speak, but chronic kidney disease, cardiovascular disease, diabetes, and metabolic disease are all interrelated. And so if you have one, you probably have an element of the other two, or you're at least at risk for having one of the other two. Well, this is about as exciting as my slides get here in bright red. But just for review, but these are the stages of chronic kidney disease, stages 1 through 5. And actually now stage 3, which is moderate, has been divided into stages 3A and 3B. And we probably should have, when we did this originally, made 6 stages, but we've now divided stage 3. And it's important that we've done that, because the patients with stage 3A, so if they have a GFR of 45 to 59, their cardiovascular risk is lower than the patients with stage 3B, so from 30 to 44. So that's why we have a 3A and 3B. Stage 4 patients from 15 to 29. And by the time they reach stage 5, that's where we're looking at dialysis or a kidney transplant, at least in most patients. So this is kidney function, which is assessed by GFR, so estimated GFR, and we have a whole host of prediction equations for that now. The most recent equation from 2021 is what we use now, the CKD-EPI equation. But on the right is kidney damage that we assess, that we measure by looking at how much protein is in the urine. And so if I leave you with something today, it's to, in addition to looking at the patient's GFR, you need to also look at their urine. And it's important that we know what the UACR is, because the more protein in the urine, the more active damage that is ongoing in the kidney. And certainly the thing that concerns me the most is a patient who still has pretty good GFR, so their overall function is good, but they're spilling significant protein. That tells me that this patient probably has hyperfiltration. It's hard to say how many nephrons this is occurring in, but this kidney's probably already working harder to maintain GFR, and if it's spilling a lot of protein, there's active damage. And so those are patients, particularly a type 2 diabetic patient that might have a GFR of 60, but they already have a 0.5 gram or more of albumin on their UACR. So those are the high-risk patients. And when we look at cardiovascular mortality, keep coming back to the heart because these are important endpoints in your patients with chronic kidney disease. So if we look at risk of mortality based on their GFR, mortality goes up with declining kidney function. But when we look at cardiovascular mortality versus their UACR, so the more protein in the urine, the higher their risk. So these are independent risk factors and predictors of cardiovascular mortality. Hopefully, you've seen this, which we call the heat map that KDIGO has been putting out there for some time, but this helps you assess the risk of your patients and what's their likelihood of progression to end-stage disease. And so on the left side, we have stages of kidney disease based on GFR, and we do have now the 3A and 3B categories in the more recent slides. And then across the top is albuminuria that is broken down into normal to maybe just mildly increased, and then a moderate increase, and then severely increased. And what I was alluding to a little bit earlier, you can have a patient, for example, that is a stage 3A, somewhere here on the GFR, but if they have significant albuminuria, their risk for progression is going to be really just as high as somebody with stage 4 disease overall. So you have to take both GFR and UACR into account when assessing for progression in your patients. So stage 3 now divided into 3A and 3B, and stage 4 when they're below an estimated GFR of 30. And we believe this is the time that you really need to intervene because there's less comorbid conditions at this stage, but also you still have some kidney function to work with. So the second thing, in addition to a UACR, that I hope I leave you with today, is to think about a clinical trial as an additional treatment option for your patients. And indeed, some of the algorithms that are out there now for certain chronic kidney disease give you recommendations for available therapies, but also to consider a clinical trial as another therapeutic option. And here's why we need to intervene earlier. This is annual mortality versus age, and the bottom curves, dark and light gray, these are patients from the general population. So obviously, as we get older, our mortality goes up. But then when you look at the dialysis population, they're on these curves here. And so whether you're male or female, regardless of what your age is, your mortality once you have progressed to end-stage kidney disease is about the same. And it's much higher than the general population. So you can take someone who is about 40 on dialysis, and their mortality is going to approximate somebody who's over 85 in the general population. So the goal over the last few years is to not get here in the first place. So all cost issues aside, patients don't do well once they have advanced disease. And along with advanced disease are all the CKD comorbidities that we have to think about. They develop secondary hyperparathyroidism. So PTH goes up. They're also in a calcium phosphorus positive balance, which promotes cardiovascular calcification. And I'll show you some photos in a bit. Potassium continues to be a challenge for us with advancing chronic kidney disease. And this is one area, maybe doesn't get talked about enough, but the SGLT2 therapies can help you manage potassium and help you continue the other drugs that your patients need. Anemia of chronic kidney disease, a challenge in dialysis patients and often in patients with late stage 4 disease. Newer therapies, oral therapies to treat anemia, unfortunately haven't done well in clinical trials, mostly because of safety issues in the CKD population. So we are still faced with using injectable therapies like Epogen, darbepoetin, and other injectable therapies that will promote red blood cell production. Worsening hypertension. So as the kidney function goes down, blood pressure tends to go up. The kidney is now trying to save itself in the best way that it can by increasing activation in the renin-angiotensin-aldosterone system, or RAS system. And then, of course, worsening proteinuria, increasing albumin in the urine is associated with increased risk as well. So I'm going to say a little bit about secondary hyperparathyroidism and where have we come in the last few years. So it's a condition where the PTH is elevated, but in renal patients, it's secondary. So often you have elevated PTH in a setting of lower calcium. And we have newer therapies to try to manage this in our dialysis patients. These are calcimimetic drugs that impact both the synthesis and release of PTH. The oral drug senecalcet and the IV drug etylcalcetide are both now used in our dialysis patients. But hyperphosphatemia, which goes along with this condition, is a big challenge for a number of reasons. When you lose kidney function, you're not able to excrete a phosphorus load. And so that leads us to using things like phosphate binders, which patients hate. If you look at the amount of pills a patient with stage 4 disease, and of course the dialysis patients have to take, my colleagues often will call it a fistful of pills that these people have to swallow, and that's more than once a day. So we've come up with binders that can help, but often we have to put these patients on phosphorus restricted diets, which they don't like. Can't blame them. I would be a terrible renal patient because I love dairy products, ice cream in particular, and so I probably run around with phosphorus levels in the 9 to 10 range. But a newer class of drugs, not a binder, a phosphate binder, works by binding phosphorus in the gut. Well, now we have a phosphate blocker, the drug tenapanor, which just got approved by the FDA in the past few months. And this actually blocks the absorption of phosphorus in the gut. So it blocks the paracellular pathway, which is the primary pathway for phosphorus absorption in the gut. And this is important. So when we look at risk factors in our patients, and on the left is work that was done by Jeff Block at Denver Nephrology many years ago. And then on the right is work that Cam Kalantar at UC Irvine did. And when we look at serum phosphorus, rising phosphorus in both of these studies shows an increased mortality. And again, that's mostly because of the increased calcium phosphorus load that these patients have and the calcification that occurs in the cardiovascular system. And when you look at the numbers, a patient who's hyperphosphatemic has about 102% increased relative risk of dying. So phosphorus has gotten a lot of attention, I guess I should say. It's really the sort of the unknown chemical, but it is certainly important. This is a cartoon, really, of two epithelial cells in the GI tract. And when we think about phosphorus absorption from the gut, in most situations, as far as ion transport, molecule transport, things go by a transcellular pathway. So there's transporters in the membranes where things get moved from one side of the cell into the cell and out across these transcellular pathways. Phosphorus is different. The main pathway actually is the movement of phosphorus between the cells. So it's a paracellular pathway. And once we figured this out, and it took a while, we realized that we could impact absorption by regulating permeability of these tight junctions that essentially keep the cells together. That's sort of the glue, so to speak. Maybe not so much glue, maybe they're more like staples. But what we're able to do now with tenapanor, this can impact by affecting a transport pathway. It's a sodium proton exchange pathway on the luminal membrane. So here's the lumen and here's the blood. So luminal side, blood side. And by impacting that transport pathway, that alters the that alters the permeability through the paracellular pathway, and in turn can decrease the absorption of phosphorus from the gut. And so the way this pathway typically works, because it's really just how much phosphorus you're eating. So the more phosphorus you have in the gut, the more you absorb. So, but if we essentially close off that route, then there's going to be more phosphorus remaining in the stool. And so I don't have any great toilet analogies like Dr. Noonan, but and that's why it's always best to go second. You know, you can steal the other guy's jokes. But the main side effect, as you might expect with this drug, is going to be an increase in stool frequency. And it gets reported in the literature as diarrhea, but it's really just more loose stools, which in this population can actually be of benefit, because often these patients are needing stool softeners and other types of laxatives, such as Miralax. So this can be a helpful side effect, actually. And I promised you some pictures, but when we look at these patients in secondary hyperparathyroidism, their elevated serum phosphorus that complexes with calcium, there's got to be some place for this stuff to go. And here's a 59-year-old patient, chronic kidney disease, on dialysis, that is showing abdominal aortic calcification. Here's a 42-year-old male with CKD now on dialysis, showing calcification in coronary vessels. And then here's another 65-year-old male CKD on dialysis, and this is calcification in the popliteal artery. So it's all one cardiovascular system. So if you're in a positive calcium phosphorus balance, it's got to go somewhere, and it winds up in the vessels. Well, what happens though if we use newer drugs and try to get the phosphorus down to a more reasonable range? And so many of our patients on dialysis, we're seeing phosphorus levels of, even with binder therapy and reduction of phosphorus intake, we'll see a phosphorus level 6.5, 7, 8. And this is data that was published just a little over a year ago. This is Dr. Fishbane's work with tenapanor. And So at screening, these patients, none of them had a phosphorus less than 5.5, but when tenapanor was added, we got significant percentages of patients that actually got to this goal. And this drug, the nice thing about it, it can be used alone or in combination with a binder. And so we saw significant improvements across the board with tenapanor therapy. Well, I don't want to spend all my time on phosphorus. I need to talk about hyperkalemia because you see this in many stages of chronic kidney disease, particularly late stage 3 and stage 4 disease. We know cardiovascular risk will increase with serum K greater than 5. And we used to think that 5.5 was okay, maybe even 5.5 to 6, but not anymore with more recent data. And this, of course, gets impacted by declining renal function. GFR goes down, you can't excrete as much potassium. And then, of course, we're putting patients on potassium-sparing medications, in particular the renin-angiotensin aldosterone system drugs, so your ACEs, ARBs, MRAs, maybe even some that are on olescarin. And then our diabetic patients will develop type 4 RTA. So how do we go about managing this? Well, we put patients, for starters, on a potassium-restricted diet, and they don't like this at all. And I've had patients, when I restrict their phosphorus, restrict their potassium, and then they say, what's left to eat? And it's really challenging. The other thing that we do will either decrease or halt their RAS blocking drugs. Not a good idea. And then we'll use diuretics, which are somewhat effective, but we've needed better tools for this. And when you look at the impact of serum potassium as far as mortality, here we are in the 4 to 5 range. But as soon as we start climbing up above 5, certainly above 5.5, and then if you add more comorbidities, such as heart failure and diabetes, the risk keeps climbing. So ideally, we're trying to keep our patients in this range, but it's challenging. So classically, put them on a potassium-restricted diet. And if you just look at everything here, here's avocados, darn it, you know, tomatoes, fruits. So we'll restrict their potassium, try to put them on lower potassium foods and drinks. And so not too bad of things here, but there's a lot of things over here that people really enjoy eating. The other thing that we do is that we either decrease or we just stop altogether one of the RAS blocking drugs. And we don't do these patients any favors when we do that, because whether it's the kidney or the heart or their diabetes, their metabolic issues, and these are mortality changes in these groups. And in the dark red, this is the maximum tolerated dose of these drugs. And the dark blue and lighter blue, this is when we reduce or stop them altogether, their mortality essentially doubles. So this is really not a good approach to managing hyperkalemia. So I mentioned the SGLT2s, and one of the ways that they help us is that in addition to blocking sodium glucose cotransport in the proximal tubule, and that helps us with glycemic control, but the natriuresis, so the increased delivery of sodium to the distal nephron, can actually promote potassium excretion. So that's one thing to help, but also we have newer binders, which are much better than the one here in the middle. I think probably most of you at some point have used SPS Kxalate, and nobody really likes, the patients don't like this drug at all, and the nurses even less, because for it to work, I'm getting back to another stool analogy, but but diarrhea really has to happen for SPS to work. So enter the two newer therapies, Lokelma, which is sodium cyclosilicate, and then there is Veltassa, which is patiromer. Both of these are selective potassium binders, Lokelma in particular. Veltassa will also bind magnesium, which may not be a good thing to be doing. So, but these drugs are indeed very effective and can work in as little as an hour. And in the hospital setting, even though it's mostly indicated for chronic management of hyperkalemia, this can even help us in the acute setting as well. Veltassa is a polymer, Lokelma is a non-polymer. This will bind magnesium and probably some calcium as well. And the thing with Lokelma is that there is sodium, there's an increased amount of sodium that gets delivered to the patients, but we haven't seen issues really with edema in the majority of patients. But so two other therapies you can think about to keep your patients on RAS blocking drugs. And this is data from the Lokelma studies. And what I've always liked about this drug, it has a very predictable dose response curve. So when you look just over a period of a few days, so this is 30 days, and the serum potassium. So depending on where you want your potassium to be, you can dial in the dose of your Lokelma. So 5, 10, and 15 grams daily. Most patients will do just fine on 5 grams daily or even every other day. So our current treatment as far as chronic kidney disease, long-standing RAS blockade, so ACE inhibitors, ARBs, direct renin inhibitors, maybe some, and the MRAs. We're striving to always improve glycemic control. The SGLT2 therapy certainly helps. Try to avoid renal toxins, the NSAIDs in particular. And finally, consider a clinical trial, because there's so many things going on right now that it's really become a treatment option for patients who have progressive disease. And I wanted to show this because there's so much news about the SGLT2 therapies and both their cardiac and renal and metabolic benefits. And these are the various flozins, as I like to call them. There's CANA, DAPA, and IMPA. And in all of these cases, we could see an attenuation in the decline of their chronic kidney disease. And this is over a period of 3.5 years. And this is the mean change in their GFRs. And so we saw improvements of anywhere from 1 to a little over 2 mils per minute. And keep in mind, these are patients with type 2 diabetes who have progressive disease. They're losing about 4 mil per minute per year. So if we can reduce that to 2, 2.5, even 3 mils per minute per year, roughly down to a 2 to 3% loss, that's a good thing. But they're still progressing. And so despite these drugs, despite better control of blood pressure, despite all the other things that we've tried to do to keep these patients healthy, we really don't have anything that's curative at this point. So this leads me to what I think is some of the most exciting things that's really happened in maybe forever in nephrology is REACT therapy. So this is the renal autologous cell therapy. This is an investigational product. The company is ProKidney. They're on the East Coast. Labs are in North Carolina. And when I first heard about this was about 7 years ago at our national meetings when I met the people from ProKidney, and they told me that they were growing kidney cells. And I said, no, you can't do that. And I started out as really a skeptic of this because we know the liver regenerates, but not the kidney. And nobody had really been able to grow kidney cells, any kind of kidney cell really, in culture. But now we've become the largest site in the world for this company as far as these studies. So my thinking has certainly changed as the data became more available and as we had more patients in these trials. So most of the patients that we've looked at have been those with type 2 diabetes. We have looked at some with congenital anomalies of the kidney and urinary tract, so the CACUT class of patients. And the patients that we've looked at have been those that are at risk for progression. So stages 3 and 4 disease, so already with significant disease, but at further risk. And so what we do is we will do a routine kidney biopsy. So this is a needle biopsy, percutaneous approach under ultrasound, and we'll harvest renal cortical tissue. And then that gets sent off to the lab in North Carolina, and these cells are isolated, and they select 3 cell types, which are termed stem cells by some. I don't know if that's quite the correct term, but I like to call them progenitor cells, if nothing else. And then they're able to grow cells in culture, and when the cells reach a significant volume, they ship them back to us, and we re-inject these cells back into the renal cortex. So this is the only company that's currently involved in any of these cell therapies, and it's been a very interesting journey with them. This all started with animal studies, and when you look at what happens in the rat model, when you inject these cells, they tend to find their way around the kidney. And so these are labeled cells, and it's really interesting. They will wind up in the glomerular region as well as the interstitial region, and they're essentially repairing and actually rebuilding areas of the kidney, which I really never thought would be possible. And here's some of the early data. We've got a paper that's being put together. So this is earlier unpublished data from the phase 2 study. So when we took these patients with diabetes and CKD, and they got randomized to either a placebo group or to an active group where their cells that were harvested got re-injected, what we saw over time, and this is months extending out to 2 years now, is that their renal function essentially stabilized. When you look at the error bars here, there is some variation, but overall, we're seeing very minimal progression of their disease over that 2 years. And these patients were essentially very similar to the patients that were in the SGLT2 therapy trials. So they were losing about 4 mils per minute, and now we reduce this to less than 1, around 0.7 mils per minute per year on average when we've looked at the latest data. These patients that were in the placebo group, when they got to 12 months, this was a crossover design study, so they got to cross over and then get the cells, and they actually did respond, but they did lose renal function. So they came down from, on average, low 30s on their GFR. They had dropped to 24, so they dropped from 32 to 24, so 4 mils lost as they were doing. But then when you crossed them over, they didn't quite reach this level, but they did stabilize and improve somewhat. So we find this to be very, very encouraging. And what does it do as far as kidney damage? Well, when we looked at the percent change in albuminuria, there was a marked improvement. So those that remain in the placebo group versus those that got cell therapy had a dramatic fall in their UACRs. So dramatic decrease in proteinuria, which again suggests a lot less ongoing kidney damage. But we also wanted to know, okay, GFR is good to look at, proteinuria is good to look at. What about some of the other renal parameters? And I had mentioned earlier anemia and phosphorus. Well, these were patients that overall had mild anemia, hemoglobins in the mid-12s. And what we saw over time in the treated patients is that they significantly increased their hemoglobins, suggestive of probable increased production of erythropoietin. It's at least one of the proposed mechanisms by the kidney. The other thing is that when we looked at their phosphorus levels and they were teetering around 4, they got down to 3.5. And if you ask many renal dietitians, they're going to tell you mid-3s is probably where they want to be. I'd probably want to be somewhere there too. But overall, phosphorus excretion improved and production of more red cells also occurred. So suggestive that we're doing more than just having a glomerular effect, that we're also impacting all of the activities going on in the interstitium of the kidney. So we're next going to be moving to a large phase 3 international trial. So in the Americas and in Europe, Australia, and in various places in Asia as well. This is going to be about 1,000 patients. So far, we have data on about 100, but we're hopeful as we expand this to a large phase 3 trial that this may lead to approval of this therapy and become a treatment option for patients with certainly diabetic disease, but maybe others as well as we continue to get more data. And finally, I just like to recognize, we talked about really a marked increase, really massive increase in studies in chronic kidney disease, but we've got a lot of organizations out there pulling for us. And so our American Society of Nephrology, along with National Kidney Foundation, we have the Women in Nephrology group, the Asian Pacific Society, just to name a few. So lots of interest now in chronic kidney disease. I think it's finally now we're maybe starting to catch up with other specialties in awareness. So what are we doing now at Boise Kidney? Lots of clinical trials. I mentioned diabetes studies, but we've been involved in a whole variety of chronic kidney disease studies. We're very active with REACT cell therapy, but we've got a lot of other things ongoing. Some very interesting work with polycystic kidney disease using microRNA therapy. I didn't have time to talk about it, and I see my clock winding down here, so I won't go into that, but feel free to ask me about that. This is injectable therapy that's trying to correct the protein deficiencies that patients with polycystic kidney disease have. And if we can correct that, hopefully we can decrease or maybe even halt cyst production. IgA nephropathy, there's just been almost an explosion of research. There's still over 20 active clinical trials, even though IgA nephropathy falls in the rare disease category. It does affect a lot of patients, and it primarily hits younger patients, 30s and 40s. So we're active in a lot of areas and always looking for new things to do. And here's how you can get a hold of me. There's my email and cell number. If you want to talk CKD, or if you think you might have a patient who would benefit from a trial, If it's something we have, great. If it's not a trial we have, I may know of it, or we can certainly look for trials at other sites. I have worked with a number of centers in the region, including University of Washington in Seattle, also University of Utah, and other locations. So I think at least considering that as a treatment option for patients could get them therapy that would benefit them years ahead of it being approved by the FDA. So I guess that's the last slide, and I finished. I think I still have 7 minutes to go. What questions?
Just some general guidelines, since you emphasize the importance of ARBs and ACE inhibitors in the diabetic population, of course, also. You mentioned almost a doubling of the mortality. Well, our struggle as general practitioners is how long do we keep them on? Do we keep it on and treat hyperkalemia, or how long do we keep those going?
My recommendation would be to keep them on forever, and I don't really have a stopping point. If their blood pressure gets too low, so if there's hypotension, that might be one of the stopping points. But now that we have more tools for hyperkalemia, yeah, well, I think now that the SGLT2s are coming on board and we're using those in much greater frequency, they're still underutilized, but I think that helps. But we have both Lokelma and Veltassa that can be used chronically, and they're very effective as far as chronic management of hyperkalemia. So I'm a big fan of continuing the RAS blocking drugs for blood pressure control and for other cardiovascular and renal benefits, but then managing the potassium. And I mean, if somebody is really eating a lot of potassium, they may have to cut back, but I also believe that we've shortchanged these patients for a long time with diets that are ultra low in potassium and also in some cases phosphorus as well. So I like to try to keep these drugs going and use some of the newer tools, SGLT2s, as well as a potassium binder. And I've had very elderly patients, for example, given Lokelma, and they may not even need it every day. They may need it 5 grams every other day or every third day, and it'll keep that potassium in check. 5 or below is great. Sure, thank you.
Hi, this is kind of a two-part question. When you mentioned that earlier referral is better, at what stage should we be sending them to you? And then the second part is, it's a long wait time. How do we address that?
Yeah, and you bring up some excellent points here, because there is a shortage of nephrologists, and getting patients in with 3A disease, which I think is a good thing, but it can be hard. And so what I open the door for people to talk with me. I may not have a trial that'll help you, but I could also be a liaison for you to talk about the case with patients that are seeing, with providers that are seeing new patient consults. And the heat map, particularly patients who have significant proteinuria. So maybe their GFR is still pretty good, above 45, somewhere between 45 and 60. So they're stage 3A, but if they already have significant proteinuria, that's a patient at significant risk for progression. So that person should be seen. Maybe it's diabetes, but maybe it's something else. So depending on the clinical history, family history, and so forth, they may or may not even need a kidney biopsy. So that's why I leave my contact info if you ever want to talk about this. And I may be able to help you directly or maybe indirectly by speaking to one of my community colleagues to get this person moved on, because sometimes when the basic numbers come in, they'll think, oh, it's stage 3 patient, we'll get to it when we can. So
Question for you. Could you lead with endocrinology? And I need to really call you. But there's some reluctance that I see in patients that I share with nephrologists even with low protein urea and GFR, say 30 to 40, and I have happily had them on insulin for 25 years. And I say to the nephrology crew, what about an SGLT2 inhibitor? Would that be indicated? And I am frequently getting pushback on that issue. And so is there something I'm missing about why one would be reluctant, other than cost and the obvious? I have to fix the insulin, but is there something that I'm missing that is causing people in your tent to be reluctant to use those drugs?
And I think everybody heard that if you had the mic there. So, well, I think there is still a lag in some of the education with these drugs. There's some nephrologists, hopefully not all, but I think there's a significant number that may still look at the SGLT2 class as being something they shouldn't use in more advanced kidney disease. And I don't agree with that. I think you should even consider it in later stage 4 disease. Sometimes when the GFR is down to say 20 or in the high teens, they worry about an additional drop in GFR. And you are going to see that because you do lower intraglomerular pressure, but that's a good thing. But at late stage 4 disease, that drop in eGFR is maybe going to be 1, maybe 2 mils per minute. So if I have somebody with eGFR 19, I drop them to 17, I'm fine with that. I'd rather have them on the drug and take advantage of all of the cardiorenal and metabolic benefits. And so I think we're still trying to play catch up with the latest data. And we certainly have got great data with both EMPA-KIDNEY and DAPA-KIDNEY. I think the drugs are way underutilized. And so if you call me, I'll say, yay, go ahead.
Okay, thank you. That's all the time we have.
Okay, there's one question maybe ask me. Yeah.
I had heard that they're doing studies on GLPs as well, and some of the cardiac benefits. Can you speak to any of that you've learned or heard of?
Well, it's an ever evolving story with the GLP-1s. And I think, gosh, what are we going to have depending on the cocktail of things, but that's likely to benefit for both glycemic control, overall metabolic disease and so forth. So we're moving towards a more precision medicine approach in nephrology. We're a ways to go, but we hope to get there at some point. So anyway, now I'm getting the hook is coming out. So anyway, thank you, everybody.